Hello, this is Saidi with my musculoskeletal presentation. The musculoskeleton that I picked for demonstration is the lumbar stenosis with sensory loss, which is most commonly caused by degenerative arthritis of the spine, otherwise known as spondylosis. Sensory loss is due to the nerve root compression leading to pain and sensory loss in the hip area, uh, down the buttocks, thigh, or leg. The condition affects individuals over 50 years of age and typically affects individuals over the age of 60. Pathophysiology. Canal narrowing from bone and ligament hypertrophy may lead to entrapment of the spinal cord as it traverses the spinal canal. Subjective data. Pain with walking or standing upright that often seems to originate in the buttocks and may then radiate down the leg. Pain relief may occur with sitting or bending forward. Pain may be worsened by prolonged standing, walking, or hyperextending the back. And the objective data in the early stages of the neurologic examination is frequently normal. With progression, the examination may show lower extremity weakness and sensory loss. A stooped forward gait may be present. Risk factors and etiology. Obesity, family history, aging, trauma, and spondylolisthesis, which is when one vertebral body moves anteriorly or posteriorly from the adjacent body, creating misalignment and worsening the spinal canal narrowing. Space occupying lesions is another factor, and fibrosis or skeletal diseases, uh, dwarfism, spinal dysraphism, like spina bifida and spondylolisthesis, are examples of risk factors. On this slide, you're going to be able to click on my recording where I showed my differential diagnosis, which include ankylosing spondylitis, and the pathophysiology for ankylosing spondylitis is inflamed intervertebral disc and longitudinal ligaments ossification that leads to eventual fusion and severe deformity of the vertebral column. Subjective data would be develops predominantly in the man between 20 and 40 years of age, begins insidiously with inflammatory low back pain and buttock pain, also involving hips and shoulders. Buttock pain can fluctuate from one side to the other. Objective data would be restriction in the lumbar flexion of the patient, limited range of motion of the shoulders, chest, wall, hips, and knees may develop, and also you would have uveitis may be present, which is eye inflammation. Next, for my differential diagnosis is a lumbosacral radiculopathy or herniated lumbar disc, and the pathophysiology for that is generally caused by degenerative changes of the disc, most commonly occurring at the L4, L5, and S1 nerve roots. Greatest incidence occurs between the ages of 31 and 50 years of age. Subjective data can be associated with lifting heavy objects. Common symptoms include low back pain with radiation to the buttocks and posterior thigh or down the leg in the dermaton of the nerve root. Pain relief is often achieved by lying down, and the objective data would be spasms and tenderness over the paraspinal musculature may be present, and then potential difficulty with hill walking, L4 and L5, or tall walking, S1. Numbness, tingling, or weakness in the involved extremity. And here are my references.